Good evening, my dear professors and colleagues. First of all, I would like to thank my dear professor, Dr. Amal, for giving me this opportunity. Today, we are going to talk about our pediatric hematological diseases and COVID-19 in practice. From the start of the pandemic in 2019 and its peak in 2020, SARS-CoV-2 has been a great burden on the whole globe with devastating and deleterious consequences. We have spent months in lockdown without international travel, wearing our masks. Many of us have lost some of their beloved ones. Our great concern was about the immunocompromised patients. So we are going to have a look about our experience in aplastic anemia patients who acquired COVID-19 infection. Several risk factors make them more vulnerable for acquiring infection. The first is the presence of neutropenia, and the lower the ANC, the more the risk, and the immunosuppressive therapy. And as my dear professor, Dr. Monet Tegi, previously mentioned, their immunocompromised state may be protective rather than harmful. So, in literature, they are talking about their higher susceptibility for infection, disease severity, and the safety of immunosuppressive therapy. Our experience, we had 8 patients diagnosed with severe aplastic anemia who acquired COVID-19 infection. Age range from 1 to 10 years, 5 males and 3 females. All of them had severe aplastic anemia, cellularity less than 10%. One of them was constitutional aplastic anemia patient and the other were acquired. 2 of our patients were already on immunosuppressive therapy. All of them, the presenting symptoms were high-grade fever, more than 39, and cough. All of them had suspicious CT findings, which were not typical, but were highly suspicious. And so, SARS-CoV-2 molecular detection by real-time PCR was done for all patients, and it was positive. These are examples of some of the CT findings of our patients. This patient had interstitial thickening and tiny inflammatory nodules. This one had inflammatory nodules. This one had ground glass patches. All of our patients were severe. Their ANC was less than 500, except one patient who had moderate neutropenia. His ANC was ranging from 500 to 1,000. All of them had positive CRP. The treatment regimen which was started for our patients, we started with antibiotics. First-line antibiotic, 4th generation cephalosporin, and we started to upgrade according to the patient's clinical condition. All of them were started on GCSF, dose from 10 to 20 mic per kg, multivitamins. Those who acquired fungal infection started antifungal therapy, and those who were on immunosuppressive therapy, we did not stop the immunosuppressive therapy. The outcome, we had 8 patients, 4 of them died and 4 were still alive. The 4 deaths were due to 2 of them died immediately from viral sepsis during the cytokine storm from COVID. 2 of them recovered but died later from secondary bacterial infection. One of them acquired Klebsiella pneumonia and had bilateral pleuropulmonary abscesses and sinusitis. The other one had gram-negative bacilli. The 4 patients who died, one of them only was on immunosuppressive therapy, but he did not show yet any response. All of them had ANC less than 500. 2 of them died from viral sepsis, the other 2 recovered. One of them died from secondary bacterial infection later with gram-negative bacilli, and the other died from Klebsiella pneumonia. Our 4 living patients, 3 of them were hospitalized. Only one of them, who had moderate neutropenia, received home treatment. One of our patients was complicated by an arrhythmia, sick sinus syndrome, as one of the post-COVID complications. The outcome of the 4 patients, one of them proceeded to bone marrow transplantation. The other one, few months later after COVID infection, entered into complete remission, and the other 2 had no change from the baseline. This was our experience with aplastic anemia patients. Another group of patients of concern were the sickle cell anemia patients in the era of COVID-19. Sicklers had increased risk of exposure and susceptibility to infection because of the more frequent medical care. They attend to the hospital many times. They had somehow immune dysregulation, functional hyposplenism, and they are at risk of acquiring more severe disease with higher risk of hospitalization and complications as pneumonia, acute chest syndrome, painful crises, and osteonecrosis. The symptoms of sickle cell and COVID-19 may greatly overlap due to that they share some of the pathophysiology, inflammation, immunothrombosis, neutrophil activation, platelet adhesion and activation. So symptoms may greatly overlap between both diseases. The most common presenting symptom of COVID-19 in people with CKD is varying degrees of pain, which could mimic vaso-occlusive crisis. Both of them can present with bony pains, fever, headache, abdominal pain, cough, and respiratory distress. As I previously mentioned, they share things in their pathophysiology, and that's why symptoms overlap. We have two cases who acquired COVID-19 infection. Case one is a female, 15 years old, diagnosed as S-beta plus thalassemia. She had previously a vascular necrosis of both hip joints, was already on hydroxyurea dose 20 milligram per kg. She had history of previous severe vaso-occlusive crises requiring exchange transfusion twice and erythrocytophoresis for 6 months. In Jan 2021, she presented with generalized bony pains. There were no chest symptoms and no fever. Her initial CBC revealed low absolute lymphocytic count, borderline platelet count, and her CRP was not that high. But her CT chest was suspicious. She had a ground glass patch, and that's why SARS-CoV-2 molecular detection by real-time PCR was done, and it was positive. This patient had a severe VOC, which was unresponsive to overhydration, analgesics up to opioids, and that's why we did hemoglobin electrophoresis, which revealed that hemoglobin S was 89%, and she performed her first exchange transfusion during the COVID presentation. She was then transferred to the isolation hospital, where she spent there 2 weeks until she had 2 negative swabs. She received supportive care, multivitamins, and then she was referred back. But when she came back, she still had generalized bony pains, which were unresponsive even to opioid analgesics. We repeated the hemoglobin electrophoresis, and it showed that hemoglobin S was 32%. And as we were stuck with her and nothing could improve her condition, we decided to do an erythrocytophoresis session, after which she improved. The second case is a male patient, 8 years old, with sickle beta plus thalassemia. He had also a vascular necrosis of the right shoulder. He was on hydroxyurea dose 20 milligram per kg. He had frequent vaso-occlusive crises every 2 to 3 months and simple transfusion every 2 to 3 months. In April 2021, he presented with fever, generalized bony pains, and productive cough. His CBC revealed leukopenia, low absolute lymphocytic count, slightly low platelet count, CRP was very high, and D-dimer was very high. His CT chest was highly suspicious. He had left lower pneumatic patch with parapneumatic effusion and multiple bilateral atelectatic bands. Swab was done for COVID-19 and it was negative, but as the patient was highly suspicious, it was repeated after 48 hours, but still it was negative. And that's why we started to manage the patient as a simple case of CKD complicated by vaso-occlusive crisis and pneumonia. He was admitted on IV fluids, antibiotics, and analgesics. Cultures were done, and the sputum culture revealed Klebsiella multi-drug resistant. During his admission, he also developed peristernal abscess, AVN, and osteomyelitis of the lumbar vertebrae. He was starting to improve, and then fever recurred again, pains recurred again, and cough also recurred. This time, the patient was unresponsive to any of the supportive measures. Hemoglobin electrophoresis was done. Hemoglobin S was less than 30%, but as the patient was not improving, we did an exchange transfusion too. 2 days later, one of the patients sitting with him in the same room proved to be COVID-19 positive. And that's why we started to doubt the recurrence of symptoms that they could be attributed to COVID-19. And that's why we repeated the CT chest, and that time it revealed ground glass opacities, and that's why he did a third swab, and this time it was positive. He was referred to the isolation hospital where he received supportive care and multivitamins. My take-home message is that aplostics are at high risk of acquiring COVID-19 with more severe disease and higher mortality. Aplostics have to be targeted with more aggressive preventive plans than normal healthy people. COVID-19 symptoms greatly overlap with CKD symptoms and might trigger VOC in CKD patients even without respiratory symptoms. Finally, stay safe, continue wearing our masks, and thank you.